Hello, my name is Arachu Castro and I'm going to talk about health and inequality. It's important to clarify the differences between equality and equity. In this graph, we see how those differences operate. In equality, an equality measure would be one that provides the same intervention to everyone, regardless of need or ability. Whereas an equity measure would be one that takes into account the different needs and abilities of different people and adapt those interventions to those different needs. When we want to analyze health data and establish differences between different socioeconomic groups, we use social stratifiers, and some of the most widely used are listed here, which are age, education, ethnicity, gender, geography, income, occupation, religion, sex, socioeconomic position, wealth quintiles, and wealth-wide poverty line. When we analyze health data along those social stratifiers and we observe differences along socioeconomic gradients or between different groups, it is important to establish whether those differences are just differences that are biological in nature or whether they cannot be attributed to the socioeconomic context or where they do. And to establish that difference, therefore, we need to understand the social context and the mechanisms that have created those differences. Differences in survival and in timing and frequency in the onset of illness and disability between and within populations are defined as health inequalities. When these inequalities stem from broader social and economic inequalities and prevent individuals and communities from reaching their best health potential, these inequalities are referred to as health inequities. And it is very important to understand that one of the largest differences between a health difference or health inequality and a health inequity is based on a concept of justice. And as Paula Braveman has defined, health inequities result from systematic, avoidable, unfair, and unjust conditions. And this is a definition that is widely used within scholarship on health equity. And let me provide an example. If we look at life expectancy, we will observe that around the world in most communities, women outlive men. And so the life expectancy of biological women is longer than that of biological men. And from our current knowledge base, that difference is the result of biological differences in between biological male and females. However, if we found in a community that men have a longer life expectancy than women, we could find social and economic reasons that would explain that reason and that difference. And in that case, we could say that if men are outliving women in a community, that is a health inequity because it results from social and economic conditions that could be prevented. However, as long as women have a longer life expectancy than men in a community, remember that those concepts are measured at a population level, not at the individual level. So if women have a longer life expectancy, we shouldn't think of that as a health inequity. It's just a matter of different biology, and there are no unfairness from events that could be redressed. Social inequality places populations who are socially disadvantaged due to economic deprivation, social exclusion, or lack of access to goods or services at an even greater disadvantage in terms of health status due to different mechanisms, and I like to divide them in 3 steps. One is the differential exposure and vulnerability to acquiring and developing health conditions. A second is to differential access to timely diagnosis and treatment. And a third one is the differential impacts of health conditions on other human development dimensions. There are different biosocial, biocultural, and political economic models that elucidate the roots and mechanisms that create and reproduce health inequities. These different models come in different names and shapes, and some you probably will hear the ecosocial model, or you'll hear social epidemiology or medical anthropology as disciplines. You will hear a lot social determinants of health, which is widely used. That was promoted by Michael Marmot in the UK, and you will hear other concepts that are very similar and are very useful to understanding health equity. And in whether they mention it or not, many times the concept of justice that they promote or in which they're based are similar or at least compatible with human rights perspectives, such as has also been defined by Paula Braveman. According to the biomedical model that you can often find in the medical literature, health processes are often thought of as universal, and they are devoid of that analysis of the context in which health occurs. And the biomedical model explains health outcomes as a product of human biology, lifestyle, and medical care. However, from an ecosocial model, it is very important to understand the specific context in which health happens, and therefore to understand inequalities in health outcomes or in access to healthcare, we need to look at it from a variety of disciplines and perspectives, and that includes human biology and epigenetics, the ecosystem and geography, history and culture, the political structure, the social culture, the economic structure, public health and social policies, and health and medical systems. Health and medical systems only explain a fraction of the differences in health outcomes. It is all these other factors that work together that makes people more vulnerable to health and disease, and or to lacking access to healthcare, or not having timely diagnosis and treatment of a condition, or to having a disproportionate impact of these health conditions in other dimensions of their lives. Some analytical frameworks to study health equity include the study of local environments, and that includes absolute deprivation, which is actually the lack of access to food, shelter, and clothing, environmental quality, the built environment, the exposure to violence, and healthcare resources. It's also important to study social connectedness, such as social support, levels of trust, social alienation and isolation, community engagement, and relative deprivation, which is poverty but to a lesser extent, and also cultural consonance. And finally, the physical and psychological stress across the life course. These models also include the study of the intergenerational transmission or biosocial inheritance of responses to stress and social adversity, such as racism, the intersection of various health conditions that result from health inequalities, and the historical, socioeconomic, and political etiology of disease and constrained agency. Another concept that is very important to understand in a health equity analysis is the concept of embodiment that has been described by Nancy Krieger again, and this is a definition that is widely used in the scientific literature, and that is a concept referring to how we literally incorporate biologically the material and social world in which we live, from conception to death. A corollary is that no aspect of our biology can be understood absent knowledge of history and individual and societal ways of living. So, how do people embody social inequalities? And let me give you some examples here. For example, when in a context of food insecurity, that is, not having enough to eat, that can cause malnutrition and stress, and as a consequence, that can limit the body's ability to fight disease by suppressing the immune system, and that can cause recurring illness and the recurring illness episodes that can increase the risk of premature mortality. In another instance, a lot of people who have acquired HIV have acquired that infection due to social and gender vulnerability. For example, women who may not be able to negotiate their sexual relationship with men who may have HIV. And they may acquire HIV, and again, that may suppress their immune systems and progress. The HIV infection may progress to AIDS, and that would also cause malnutrition and stress. And we go back to the previous example as to how that could increase the risk of premature mortality. And finally, we have another example, which is in a war setting, in places where there are landmines. Those who are most affected by landmine explosions are children, because they are closer to the ground, and a landmine explosion could cause either death or the loss of limbs, and that could cause limited mobility. So imagine a child who loses a leg in a rural community which is at war, and it would be difficult for that child to have timely surgery, to use a prosthetic. But even if the child were able to access that surgery, that prosthetic would need to be upgraded as the child grows. So it's going to be difficult for that child to access, without proper mobility, to access a school system in a rural setting. Even a wheelchair may be difficult to manage in a rural setting, and that lack of access to education could also hamper the child's opportunities in employment, and in the midterm that could also create food insecurity. And we go back to the first example and how that could eventually increase the risk for premature mortality, even if the child has survived the landmine explosion. Another concept that you will often read about in the analysis of health equity is that of absolute and relative differences. So here in this graph, you have, in the red line is, let's say, infant mortality between 2005 and 2020, and the red line is how infant mortality has decreased for the lowest wealth quintile of the population. And in the orange line, we see the same indicator, but for the highest wealth quintile. We see that in both cases, the infant mortality has decreased, but there's still differences that exist. In this graph, we observe the difference in as an example, infant mortality between the wealthiest and the poorest wealth quintile, and we see that in 2005, for the poorest it was 50, and for the wealthiest it was 25. So the difference between the two is 25, and that is the gap. And in 2010, that difference has decreased, and the poorest are at 25, and the wealthiest are at 12.5, and therefore, again, the difference, the absolute difference is 12.5. So we see here how absolute differences decrease substantially from a gap of 25 to a gap of 3.1. Here we have the same data, but instead of looking at absolute differences, we're looking at relative differences. So, for example, when we look at the indicators for 2005, we see that for the poorest is twice as large as for the wealthiest, because it's 50 divided by 25, and that is 2. And that same relative difference is exactly the same every 5 years. So the relative difference here hasn't changed between 2005 and 2020. And that is why addressing relative differences can be much more challenging than addressing absolute differences. In 2019, the Commission on Equity and Health Inequalities of the Pan American Health Organization published a report that was led by Michael Marmot, and that includes this graph on the intersectionality between social and economic inequities, gender, sexuality, ethnicity, disability, and migration. And this graph reflects really clearly how the structural drivers create conditions of daily life that are it's what increase or decrease the risk of people of having a dignified life and of establishing differences or not between different populations in terms of health equity. If you are interested in learning more about health equity on reproductive, maternal, newborn, child, and adolescent health, I encourage you to read the Health Equity Report 2016, which was a collaboration between UNICEF and our team at Tulane University. Although it is focused on Latin America and the Caribbean, it includes a review of more than 700 sources and explains how all these different mechanisms that I have explained thus far operate, and what are the social and political forces that help explain all those differences, and also how to address them. So I really recommend that you take a look at this report.